Hello, everybody, and you're all very welcome to our first webinar, hopefully in a series of webinars over the summer months and possibly beyond, as we adapt to COVID-19. My name is Daniel Hoy. I'm Research Coordinator with Focus Ireland. And today we're delighted to welcome Dr. Austin O'Carroll as our speaker today, and we're very grateful for his time at the moment. I'm aware that he's extremely busy in his role as clinical lead for the homeless COVID-19 response. If I was to go through all of Austin's achievements, it might take 10 minutes or so. So I'm going to provide a brief introduction, Austin, if that's okay. Austin is an inner city GP since 1997, and the focus of his career thus far has been improving access for marginalised communities to quality healthcare. He has founded several initiatives, including Safetynet, GMQ, and GP Care for All. Austin has also completed a doctorate in ethnographic research into the health service usage of homeless people. And indeed, that will be the topic of the presentation today. So this presentation will run for approximately 40 minutes, followed by questions and answers. Austin has an engagement directly after this, so we might have to wrap up about 5 to 2 or so. Attendees can ask questions via a tab you should be able to see on your screen. There's a questions tab, and you can pop questions in there. I can keep tabs on those questions and collate them for a question and answering session at the end. So if you have any questions, please use that tool that's on your screen. So as I said, this is the first webinar we're trying, so bear with us. With this, our next webinar is scheduled for the 27th of May, and the speakers on that day will be Mike Allen, Director of Advocacy and Research in Focus Ireland, with Ono Sullivan, who is Professor in Social Policy in TCD, and they will be speaking to a book they co-authored entitled Ending Homelessness: The Contrasting Experiences of Denmark, Finland and Ireland. In this talk, they're going to hone in on the Irish experience, and that should be very interesting in light of Homeless Services response to COVID-19 and indeed the priorities of a new government that may be formed over the coming months. I hope you can join us for that chat, and details will be shared via the mailing list in the coming weeks. My contact details are there on the screen if anybody wants to give me a shout if they're not on that mailing list. So without any further ado, I'm going to change the screen here and pass this over to Austin.
That's great. Is that okay now? Can you see me, Daniel, and hear me?
Yeah, I can hear you, yeah, loud and clear.
Yeah, fire ahead then. Thanks very much to Focus for asking me to talk, and also thanks to everyone on a lovely sunny day for joining me over lunch. I'm just going to describe research I did, which was trying to make sense of why homeless people use health services very differently from non-housed people. And in this, I'm going to presume people don't know about research, so I'm going to just try and talk from a very simple level. But there are some parts where I'll be describing some research details that may sound a bit complex, but it won't take long, so apologies about that. I think the best way to start is about yesterday when I saw a patient of mine who I first saw around 6-7 years ago. And this was a patient who we saw, and she had just been diagnosed as having an X-ray which was very suspicious for tuberculosis. And she was a person who was quite frail, so was someone who we were worried about their health. So firstly, we actually met with her and said, listen, we need to get you into hospital tomorrow to get this checked out. We'll get you into your own hospital for the night. We brought her up to the hospital, and We told them, listen, she needs to be put in a room on her own because we just need to check her for TB, which was a bad mistake on our part because immediately they threw her out. And the interesting thing was they threw her out, and then we spent 8 days looking for her. And we eventually found her under a bridge, sleeping with her boyfriend, in sleeping bags. And we met her and told her how important it was for her to go to hospital. And she told us very nicely, in usual language, to go away, much nicer than that. And then we spent the next 3 days trying to persuade her, and eventually had to cajole her with the promise of methadone and tablets to go into hospital. And we spent the next 9 months, because you have to spend 9 months on treatment, trying to cajole her, trying to persuade her to stay on treatment. I remember one particular meeting when we had 3 consultants, 4 nurses, and a team of SHOs in a room, all trying to figure out what would they do because she had stopped taking her medication. And I said, has anyone asked her why she hadn't taken her medication? And they said, actually, no. So we rang her. And she said, because we send nurses out every day to give her TB medication. And the first thing she said on the phone was, Jay's that. She says, they knock on me fucking door at 9 o'clock in the fucking morning. She says, I don't get out of bed till fucking 12 o'clock. And so I turned to the consultants and said, is there any way we can go later? And we couldn't. So then we came up with another method of doing it through the pharmacy. The point of this story is that obviously, if you or I got TB, and we're not that frail, most of us, the first thing we would do, if we were told we had to go to hospital, we would rush into hospital the next day, and we wouldn't even question the doctor, and we wouldn't think of not going in. It wouldn't even enter our minds. So how come this behaviour where homeless people, and this is not just her, just come across this frequently, decide to not take their health seriously, avoid going into the doctors, avoid going to the GPs, the hospitals when we expect them to go. And this was the question I wanted to address when I did this research, and it's called Making Sense of Street Chaos. And I published an article in the International Journal for Health Equity on this, Making Sense of Street Chaos, and you Google that, you'll get the article. If you were to provide a health service for one group of people, it would be homeless people. They have the worst health indices in the Western world of health. We know the average age of death for rough sleepers is 45 to 46 years. We know that from research that Fiona Riley and myself conducted in the past, that 1 in 20 homeless people have hepatitis B, 1 in 20 have HIV, and 1 in 3 have Hep C. We know they have higher rates of lung-related disease and heart-related disease. We know from a mental health, 1 in 2 have depression, and 2 out of 5 have anxiety. And you can imagine, well, why wouldn't you if you were homeless? But when you put that into context, that 1 in 3 have attempted suicide within their lives, and 2 out of 5 in the last 6 months, that really puts a context that it's really serious depression and really serious anxiety. So they have terrible health indices, and if you were to have a health service for one group, it should be there. This is the research we did, Homelessness and Health State, which give a number of those statistics about the health. Unfortunately, we also looked at the access to services in this research and an earlier piece of research we did in 2005. And there's a famous law called Tudor-Hart's inverse care law, which states that those people, the need for services is inversely proportional to the provision of services. But in simpler language, the people who are most likely to need healthcare are the ones least likely to get it. We know this from our own young people. We know people in areas of deprivation have the worst health indices and have the worst access to healthcare and hospitals, etc. So, and in terms of waiting lists, etc., they have much worse healthcare. When it comes to homelessness, we found that even though every homeless person was entitled to a medical card, when we first did it in 2005, 55% had a medical card and 45% didn't. Even of those who had a medical card, many of them didn't use it. So this is why we did this research. And this picture I call guess who the researcher is. This is me talking to, I was out, ethnography is about going out and becoming immersed in the culture you're investigating. And in this idea, whether you call homeless culture or not is a debatable point. And if you take it that it is, I was immersing myself in homelessness. And that meant I would go out on the street, and I basically went to 4 different hostels. One had 2 drop-ins, a food hall, and I would sit there and chat to people. This was over a year. I'd spent an afternoon a week doing this. And then I also conducted 47 semi-structured interviews. And I also spent one evening a week out in the streets talking to people like this, going out with the Rough Sleeper team. I conducted 2 focus groups with hospital doctors and homeless people. This is the sort of techie bit. What I took is what's called critical realism, the epistemology. And the reason I took this particular approach is homelessness can be seen as, there's an idea that homelessness is it real or is it what we call a constructive entity? And in many ways, homelessness is a constructive nature. What do I mean? When you say is, what do you mean by not having a home? Does it mean that you don't have a roof over your head? Well, many homeless people do have a roof over their head. Does it mean not having a room to yourself? Many homeless people do have a room to themselves. Does it mean not having a place of safety? Well, many non-homeless people live in homes where they don't feel safe. So exactly what a home is quite debatable, and exactly what homelessness means is also debatable. So that's what I mean by the constructive nature of homelessness. I also meant is that I work in the inner city as a GP, and in practice, and I also work in homeless practices. I would find that some days I'd be in my practice and I'd meet a client and chat away to them. Then 6 months later, I'd be in my homeless practice. The same client would turn up and I'd say, "What are you doing here?" And they said, "I had a row with the parents, or I started using drugs and I was kicked out." Then 9 months later, I'd be back in my practice. Next thing I'd meet, he said, "Oh, we made up with the mom and the man and the dad, and we're back together, back in the house." So this idea that homeless is a state, whereas a lot of people just drop in and drop out, some people get caught in long term. But it being a real thing is debatable. However, there is a definite reality to the homeless existence, and it's a very stark and difficult reality, and all of us working in homeless services know about that reality. That's why critical realism straddles what we call social constructionism to realism. I'm going to, so this is the last one of the techie bit. In research on critical realism, you try and this is what we call the empirical level. That's what you experience in front of you, you see in front of you. The actual level is what actually is happening, because when you're at the empirical level, you're putting your own interpretations on what you see. So I see someone and they look, they have a very bad health condition, because, for example, I saw a guy one day when I was at the research and his ear was slashed in half and it was bleeding profusely. And I thought, Jesus, that's really bad. Whereas at the actual level, he didn't think it was bad. From his perspective, it was fine. So he just wrapped it up and went around. So there's my different understanding of it versus his. The generative level is trying to understand why is it that he went off and didn't go to hospital where I did. So that's the social causes that happen deeply that cause people to generally behave in certain ways. That's all the techie. First of all, how do homeless people health behavior differ from everyone else? Well, first of all, is they often leave it to the last minute until the illness is overwhelming, or the symptoms are just they literally can't cope with. So, like a woman, she had this TB, but the symptoms of the breathing, she was coughing, but she wasn't short of breath. So she probably was more likely to wait till it's overwhelming, she can't breathe. Imagine people with DVTs come into me and I say, "You need to go up now," and they say, "I'll be fine." And I say, "But you could have a clot to your lung at any minute." They say, "I'll be fine." Or people with abscesses who need IV antibiotics, they say, "Listen, I'm fine." And I say, "You need IV antibiotics," and they won't go. So they delay treatment at the last minute. They also tend to leave treatment often. So, for example, I had 30 people who were needing hepatitis C treatment. Sorry, I referred 35 people for hepatitis C treatment, of whom 23 went for their first appointment, 3 went for their second appointment, and 2 completed treatment. So they tend to, where they go, they tend to leave. Similarly, in hospital, many homeless people go into hospital, but they then leave against medical advice before their treatment is completed. They tend to have very low usage of primary care services. They tend not to use GPs, and they tend to have very high uses of emergency departments. Clean and Kelly did research on this, I'm moving back. Peely Kelly did research on this, and she found that in James's and the Mater, homeless people accounted for 10% of emergency department attendances, despite representing less than 0.5% of the population in the catchment area. So similarly, they tend to have very high hospital admissions, and similarly, they account for 10% of bed days in both James's and the Mater, despite representing less than 0.5% of the population. They tend to have poor compliance with medications. You know, they won't take the medications they're supposed to, and they tend to avoid psychiatric services. This is particularly so for people who have a long history of mental health problems and probably have negative experiences in the mental health system, so they tend to avoid. And this has been in the literature, this is the way they behave, and in my research, I found the exact same findings. They behaved in these ways. This is the summary of those things I was saying, where they had no medical card, 45% in 2005, 25% had a medical card in 2015. Even those who did have a medical card tended not to use it. ED attendances, they're the research I quoted earlier on. So this is the model I devised from my research, and someone once told me that every researcher has a model of whom only two people understand it, the researcher and the supervisor. So this was my model, but I'm going to go through it in more detail from a story point of view. First of all, I wanted to find out why did they behave this way. And the first thing I identified is what I call external barriers, barriers existing outside the person that prevents them using the health service. So the first barrier was simply physical barriers, and distance is the most common physical barrier. So homeless people may have a medical card in Blanchardstown, but that's too far to go. They may even have it in Inchicore, but that's too far. Some of them had it in Mayo and Sligo, which is obviously too far to go. So distance was a significant deterrent for the use of services. And that's why most homeless services actually tend, along with all the other reasons why we tend to bring homeless services to where they are in the hostels. If you want a homeless person not to use your service, get them to fill a form. If you want them to definitely not use your service, make that form as complex as possible. And if they're Eastern European or non-Irish, don't provide any translation service for them. The medical card form is a complex administrative form and makes it very difficult. So every time you have a form, it is a barrier to the usage of that service. Appointments. Appointments, not everyone keeps appointments, but homeless people are terrible at keeping appointments. If you think about it, appointments are really designed for people who have cards, who've got clocks, who are good at timekeeping, who have order in their life. They're not designed for people who chaos, who don't know what they're doing day to day, and don't have a diary, and don't keep a sense of what they're going to do on a day-to-day. Queues. Again, everyone hates a queue. Well, we all know people who are working in homelessness, they tend to be very hyperactive. They tend to find sitting down still very difficult. And the amount of times I've seen people homeless people, you can almost spot them because they can't sit still and they're getting very edgy. The amount of homeless people who come back to me and says, well, it's too long a queue, I couldn't stay in casualty. If this queuing is exacerbated if you've got an addiction, and if you go in and go to the end of the queue and you're addicted to heroin or alcohol and you're waiting there 5 or 6 hours and you go into withdrawals and you go out and take a drink or get a shot or shoot up, when you come back in, because you left, you'll be put at the end of the queue. I call it the never-ending queue. The amount of times I rang up trying to explain to people why they had to leave, and the casualty person would say, well, listen, the policy is you have to go to the end of the queue. Now, I know things are changing, but also we don't provide methadone to people who are waiting. I understand why, but it does create complexities. Rules of services. You've got to understand, most people who live in homelessness come from traumatic backgrounds and have adverse childhood experiences. For them, rules were enforced with stick and fist. When someone starts enforcing a rule saying you must do this and you must do that, they literally go back to the child within and they act the same way as they would have as children. And that's why they kick off. That's the way they have learned to survive when people end up forcing rules. So when you enforce rules strictly, you become sort of a self-fulfilling endorsement of why you should enforce rules. So, for example, I've visited a few hostels and services where they have reverse mirrors, locked doors, security guards. And I'd say to them, why have you all these? And they say, because we're very dangerous people. Everyone who works with homeless people works with dangerous people. We work with them every day. We have a different way of enforcing rules. We persuade, we cajole, we joke. Tommy, who works with me, is a fantastic character. Only a few weeks ago, a guy was kicking off and saying, "Tommy, I'm getting really angry. I'm going to hit you." Tommy says, "Hold on, hold on." And he pulled out his false teeth. He says, "Now you can hit me." And your man laughs. Even though that sounds like a joke, it was a really skilled intervention. And so we have ways of talking people down and saying, "Come on, sense." So the enforcement of rules is much more complex than just "you have to do this and you shall." The presence or absence of information is a barrier for everyone and also for homeless people. This was probably one of the biggest barriers, stigma and discrimination. I'll tell a story to give you an example. I had two clients who originally were sleeping in Stephen's Green in a tent, addicted to heroin, cocaine, and alcohol. They were there for 3 years. One Sunday it was lashing rain and they were freezing cold and there was no surface to drop into. And as they were wandering around, he started to become hypothermic, so they went to hospital. He was losing consciousness, and as they were taking off his clothes with the scissors, the doctor turned to his partner and said, "This is disgusting, the condition you've got into." When he recovered, they both left early, and they said they swore they would never go back to casualty unless they absolutely had to. And the sad thing about that is those two same clients went into our Safetynet mobile health unit a number of months later, met a lovely GP trainee who referred them down to Merchants Quay, where they met the fantastic Clean Kelly, who referred them up to us for methadone treatment and to Simon for alcohol treatment. They got their own home. They both did pre-university courses. There's a sad and a happy end to this. The happy end is that one of the couple is now in university in her 3rd year of, and it's in Trinity College, so it's a really good university in her 3rd year, doing brilliantly. Sadly, I think he unfortunately had a little breakdown as he came close to getting into university. I think the expectations started to get to him. And I think he found it difficult to cope with the fact that he wasn't able to keep up with where he thought he was going. He felt he was going backwards. Very sadly, he committed suicide around 6 months ago. I interpreted it as that his adverse childhood experiences got to him and his hope and belief in himself lapsed. And then as he saw his partner do very well and he wasn't, I think it created this difficulty for him, and it was very sad. But I still think the doctor getting him into the treatment and her into the treatment was the right thing to do. And my sad thing, going back to the original doctor who showed stigmatizing attitudes, and I don't blame that doctor, to clarify, that doctor was just displaying the stigma of society, and then you put that stigma into a pressure cooker of a casualty where everyone is stressed out, you're going to get worse stigma, particularly when they're overwhelmed with homeless people and with issues. So it's a breeding ground for stigma. But that doctor entered medicine to help people and save people's lives. And not only did he cause them not to attend casualty, but he lost the chance to have a dramatic influence on someone. Another thing I identified, or what I call attitudinal barrier, was what I call conversations of exclusion. The benzo conversation, the mistrustful conversation, the blaming conversation, the assertiveness conversation. The benzo conversation is very simple. It's where I identified the conversation that frequently ended up in a breakdown between the doctor and the patient. So the patient asks for benzos, saying, "Doctor, I need benzos." The doctor says, immediately gets annoyed because we all know bad doctors prescribe benzos. We're told it all the time. So I'm not a bad doctor. So they get annoyed and they say, "I'm not that type of doctor, or I don't do benzos." And the patient then, who needs benzos because they go into withdrawals if they don't get them, says, "Well, why aren't you that type? Why don't you give them to me? I need them." And you end up deteriorating into a row where the doctor has their attitude that the patient is just a no-good layabout confirmed, and the patient has the attitude that the doctor doesn't care confirmed, and both parties separate and lose out. We teach our doctors a different way of doing the benzo conversation since we identified this pattern. And what we do is I say to a patient when they ask for benzos, like this morning I had a request, I said, "Listen, I'm really sorry, but we're not allowed to prescribe benzos, but the medical council won't allow me over prescribe them." And they say, "But I need them." And I say, "I really understand you need them, but I'm really sorry we're not allowed to do them." And they still will come back, and I keep on doing the broken record saying, "I'm really sorry I'm not allowed." But I try and convert it into a positive by then saying, "But listen, I can help you with coughs, colds, and chest infections. I'm really good at them. So can I help you in those?" They don't necessarily ask for the help. They simply often go out annoyed, but they come back, and I will have them back. So it doesn't lead to a breakdown. Mistrustful conversation is where a doctor has been told a lie. Many doctors believe if you tell a lie, it needs an end to the relationship. And I think that's because they've confused romantic and medical relationships. In a romantic relationship, I generally need to trust my partner, absolutely. In a medical one, it's very good to trust the patient, but because I know patients are forced to tell lies by drug addiction, I don't have to trust them, I like them. And I'll often say to patients, listen, when they tell me that the tablets have been lost for the 10th time and down the toilet, I'll say, listen, I'm really sorry. I said, I never know who's telling me the truth or not the truth when these tablets are lost. I said, I'm sure you are, but just because I never know, I can't replace them. I'm really sorry. I think by naming it makes it much easier, and they sort of know it themselves. So I don't ever have a difficulty with that. Blaming conversations I talked about is where doctors blame the person for becoming homeless and being addiction. And just to clarify, the big cause of addiction and homelessness is poverty. The statistics are overwhelming. Poverty and the association with adverse childhood experiences are the big causes for homelessness and for drug addiction. As well as poverty, mental health counts for around 20% of homeless issues as well. So the blaming conversation is where you don't recognize that it's societal causes and you blame the person. It's the individual fault hypothesis, same as the doctor saying you're at fault. The assertiveness conversation is going back to the idea about rules. I saw this where I met a guy on the street when I was researching who said he had chest pains, and I said, you need to go to hospital. And he says, I'm just come from hospital. And I says, I left because they wouldn't treat me. And I said, I'll bring you in. We went in, and I went up to the reception. I said, this man needs to see a doctor, and I let him go up. I sat down thinking, that's great. Within 3 minutes, I heard him shouting at her and heard saying, go away, I'm going to call security. So I ran up, got him to sit down. I'm really sorry about that. And then I said, listen, I'm really sorry. I know he shouldn't behave that way, but he actually has chest pain, and my name is Dr. Ross. He needs to be seen. What I was doing was asserting myself in the middle class and also using my doctor type to assert myself, because I have the good skills for assertiveness that are acceptable at middle class level. He was asserting himself in the way he'd learned to assert himself, which is not acceptable within our system. And that's where I see there's a mismatch of assertiveness techniques. Whereas, interesting, after doing the ethnography, I find I'm much more likely to have a row with patients, and it's sort of, in a way, I act the same way they would act. Like if someone gets up and starts giving out to me and raise their voice, like, come on, you relax. I find that I've always gone towards their way of asserting themselves. Obviously, I'll be careful in saying I'm not doing this all the time, but I just noticed that there are different ways of asserting this. They find it acceptable sometimes often to do it that way because that's the way they've learned. It's not about being aggressive, it's just about recognizing different assertiveness. As well as external barriers, I also identified what I call internalized barriers. And these are not internal barriers, they're internalized. What I mean by that is they're cognitive inhibitors, which are thoughts, or emotional inhibitors, which are emotions or feelings. These were thoughts or feelings that the person had internalized from their external environment. And I'll show you what I mean by that. So, the internalized barrier, fatalistic cognition. I don't care about my life, I can see death in me. If you think you're going to die young, then why bother taking care of your health? And why is this an internalized barrier? Because in homelessness, you look around and you see young people dying all the time, so you obviously create an expectation that you're going to die. Another version of it is I saw a guy who said, listen, I'm 36, I don't have a partner, I don't have a job, I don't have any kids. What is there in life for me? This is at the age of 36. That leads to a fatalistic cognition. If I'm going to die, why bother taking care of my health? Denial cognitions are another version of it called deferrals to future cognitions, where you move things to the future, are basically very common. I'll be fine. So you have a clot in your leg, that clot will go to your lung and kill you. It won't, I'll be fine. You have an infection there that's really not been responding to antibiotics. You need to go on IV antibiotics, I'll be fine. Very common. And I think it is a way of surviving homelessness. If you deny, I mean, you live in the existence of homelessness and you actually took the full reality of that, it would be overwhelming. So I think denial is a very good skill for surviving homelessness, not a very good skill for managing your health. This is the presumption of poor treatment. That's why it says it's internalized. If you presume, the presumption of discrimination, the presumption of poor treatment. So there you've internalized, I'm going to be treated badly, I'm going to be discrimination, so there's no point in going to that service. So I often see people who say, We run great services, and we don't have to refuse homeless people. The reason they don't have to is homeless people know you don't go there because they've had bad experiences in the past, so you don't get anyone visiting. An even worse way of internalizing that is you actually take it on. You say, actually, I am at fault myself for my homelessness, my addictions. I'm to blame. So you've internalized the blame, and you then then there's also what we call the need to survive cognitions. This is known in the literature also as competing priorities. If you were to do Maslow's triangle, and most people at the bottom is food, and then housing, and then as you go up, there's emotional needs, and eventually self-fulfillment. If you take drug addiction and homelessness, there's another layer on the bottom, and it's full of alcohol and drugs. And the first thing they have to do when they get up in the day is go get money to get alcohol or drugs. They have to go tapping to get money for alcohol or drugs. After they've done that, they need to get food. Then they need to get accommodation. Health is very far up that priority list and often not reached. That's where the competing priority means they often don't turn up for appointments because of these. In terms of emotions, fear, strange enough, a lot of homeless people can be afraid. They can be afraid. And one of the things is violence. I found was really interesting. Violence is endemic in homelessness. Many people feel terrified going down the street. So they will avoid places, and often, particularly drug clinics, they don't want to go to a drug clinic because they're afraid of violence. Also, you find homeless people who won't go into hostels because they feel hostels, there's violence in hostels. And there is a reality to that. The rates of violence and sexual violence in hostels are particularly high. I had a client, this is going into institutionalized stigma, who she came up to us from Midlands town because she couldn't get methadone treatment in her Midlands town, and she became homeless to get onto methadone. She was in her early 20s, and she had a 4-year-old child in the country. When we met her and heard her, we got her onto methadone as quick as we could, and then we gave her methadone. We got a pharmacy in her local town, and we got her to go back to the pharmacy. We couldn't get a local GP to take her on for methadone, so she'd have to come up once a week to us. One week she came up, and we didn't realise it, but she'd stay in a hostel the night before. She'd go up the night before, stay in the hostel, come into her clinic then. When she was in the hostel, she was violently sexually assaulted, became very depressed, went down the streets and died from an overdose 3 days later. And her child is now motherless. And I blame the GPs and the institutionalized stigma in general practice for that. And I don't blame them individually, I blame the institution. So fear is a big thing of violence and sexual violence. Fear was another one. I would be terrified of getting HIV or Hep C because it just feels terrifying to me. When you're in homelessness and you meet all these people who've got HIV who are surviving quite fine, or hepatitis C and they're surviving quite fine, you lose that fear. And that means they're more likely to take risks. Interesting, lack of fear was also an issue. Hopelessness was a big problem. If you don't hope for a better life, and it's like if you don't hope to live a fulfilling life, why bother taking care of your health? The reason we take care of our health is because we hope to live long, healthy, happy. Embarrassment. A number of homeless people were embarrassed waiting in queues. They were embarrassed about their smell, their clothes, and so they felt uncomfortable in waiting rooms, particularly in general practice. Low self-esteem, which goes with hopelessness. If you don't think you're worth it, then you don't think it's worth. You think, I'm only bothering the doctor, and I'm not really worth their attention. That was a significant problem. Anger was a huge issue, as I said about certain cells. Anger often led down to breakdowns. And often people would say, well, I'm not bothered with an angry thing. I'm not, because you blame the doctor. In fact, you wouldn't go to them and your own health would lose out. Even though you're angry and you think you're making the doctor suffer, ultimately, the homeless person's health is losing you. So these are all the issues I identified. But then I looked at, well, what were the deeper generative causes in society? And the generative mechanisms are things that started prior to becoming homeless. So first of all, as I said, poverty, I think, is one of the big determinants of these type of behaviors. If you have low expectations, if you have family dysfunction, substance misuse, these all affect your thoughts, the way you see the world, the way you navigate the world, the way you think of yourself, your fear of authority, your illiteracy, your ability to fill in forms, etc. Mental health is also another significant issue that exists prior to becoming homelessness. So a number of the two issues of poverty and mental health, the two issues that prior to becoming homeless that affected these issues. determined why people had these external or internalized barriers. So, for example, family dysfunction means that you're likely to learn how to assert yourself in a very aggressive way, which means that you assert yourself in an aggressive way, which leads to relationship breakdown, which means you end up losing out on face stigma and subsequent to becoming homeless, the degenerative mechanisms are identified for a lack of appropriate accommodation. If you're managing your accommodation, you can't take care of your health. Ubiquity of early death. As I said, if you see people dying around you all the time, then you become fatalistic about their health. The fact that you have to survive means you do prioritize your immediate survival rather than your long-term health. So things like screening, preventative health become less important because they're not, it's the immediate survival you prioritize. The chaotic nature of homelessness is chaos out there, on the streets, and that contributes to the factors that we described in the external and internal barriers. Negative experiences of authority, and stigma and discrimination that you experience in hospitals is only part of a wider stigma and discrimination against homelessness, and particularly against drug users that exist in society. Last thing, the affected territory, and this I noticed once I was in Casualty. And when I was in Casualty, I was sitting there, and I was doing this as part of the research. I sat there one day, and everybody was sitting around chatting. And suddenly the door opened, and in walked these two, what I looked like homeless people or drug users, or both. Immediately the whole room, the waiting room, went quiet. And the two lads sort of talked very loudly and aggressively, and they walked around the side of the room as if stuck to the wall. I walked up to the toilet and went in and talked loudly in the toilet, and then they came out again and talked aggressively, and again stuck to the walls and went out the back. This was in the Mater Casualty. I don't remember the old Casualty where there was steps out the back. They went out to the steps. And I was sitting there, and I said, I decided to go, and everybody starts talking again. Everybody obviously frozen in fear. And I went out to the steps, quick back out in the steps. It was like being in a kitchen at a party. They were drinking, they were telling stories, having jokes and laughing, and they were much more at ease. So both the homeless people were more at ease out in the steps, and when they weren't intermingling, and the people who were non-homeless were more at ease inside in the waiting room when there was no homeless people there. It was like there was two different territories, and that sense of ease in my territory was another barrier. And I suppose to me, one of the ultimate conclusions I came to was that we design health services for people who are housed, not for people who are homeless. If you were to design a health service for people who are homeless, it would be somewhere where they could drop in anytime from 12 o'clock at midnight right through to 12 o'clock the next day, midnight the next day. They could have a place to sit, a place to sleep, and they would be seen by doctors whether there was a minor complaint or a major complaint. In other words, casualty. That's why they use casualty so much. When you redesign services it means about bringing primary care services to homeless people, bringing drug services to homeless people. And that's what we've done with services to Safetynet, GMQ. We've brought primary care services to, I think, 16 drop-ins and 11 in-reach services in Safetynet and GMQ in Dublin. We have the mobile health unit for homeless people. We have the mobile health screening unit going around screening homeless people. We have the addiction services, which has now got over 220 people on methadone treatment and started over 650. Not surprisingly, we found that when 80% of people you start on methadone, their accommodation status improves within 3 months. So hence why addiction treatment is so important. We also provide addiction treatment for benzodiazepine and alcohol. And we did an interesting one, those hepatitis C people where I said the 35 of only 2 got treatment. We brought the treatment to our drop-in service, and all the people have received treatment now. So it's about redesigning the service to suit the needs of homeless people and to suit their health service usage. I'll leave this slide because I think I'm talking to an audience who know that homelessness is not an individual choice. And I think I'll leave it. I've finished that. That's 40 minutes you told me to talk for, Daniel. I think I've reached 40 minutes.
Thanks very much, Austin. Can you hear me now, yeah?
I can hear you clearly, yeah.
Okay. Well, thanks very much, Austin, for that very thought-provoking, fascinating presentation with obviously some very serious, very stark findings in terms of highlighting an exclusionary system for this health system this marginalised group. It's not fit for purpose in a lot of ways, and also for providing a clear articulation of those kind of complex internalised barriers. So thank you very much. So I have a question for myself to kick things off. I read the paper a number of weeks ago, Austin, and I was curious about the ethnographic element. You know, I'm a trained researcher myself, and I find that very fascinating. But I was wondering about how you address the research bias, given your position in that community as an authority figure, let's say.
It's the intuition of positionality. And basically, obviously, one of the potential biases was that people would see me as a doctor, and that would, obviously I was a doctor to many of them, so that would obviously affect how they would interact with me and what they'd say to me. And then also they would be even knowing me as a doctor to change the interaction. And actually, I found a really helpful paper. I can't remember the name of it now, but I can get it out for you. And it was a person who was actually known as the professor in homeless services. And he talked about the fact that he felt is that what you needed to do when you're approaching homeless people is just, you have to lay out your background at the start, be upfront, because there's no point in trying to hide it. And there's no point trying to deny that I'm a doctor. So I would explain I was a doctor, but I was here as a researcher. But he says then, if you engage in an authentic fashion then, he says, and be authentic to yourself, he says, eventually people lose the perspective of who you are. And he says, and in that authenticity, you have to be, like, for example, I at one stage early on was talking to some clients, and they were talking about giving out about black people, and it was quite racist. And so what do? Do you join in the conversation? No, you don't do that. I had to be authentic to myself and say, no, I don't agree with this. And I found the way I became more authentic was I interacted in the same way as they were. I wasn't, you know, I got quite engaged in it. And, you know, they're full on, they're quite active and they're engaged, and I did the same. And I found I suppose that would be, it wouldn't be unnatural for me to engage. In my own family, we used to become very, you sit around a table and become very incensed in arguments. And if I reverted to that, it became quite normal for me. And I think that authenticity allowed me engage in a way that allowed that perception go away. It doesn't always go away, and you always have to be careful that you're interpreting. So that's where you then have to reflect on your findings and see how could this have been influenced by the fact they know I'm a doctor. Does that give you?
No, that's great. Yeah, thanks very much. So I have another question here, Austin, from Rihad, who's the policy officer for Cross Care and the migrant project there. And Rihad asks, on a policy level, how can we address the inverse care law in terms of health economics, resources, and financial cost?
Okay, big question. My own belief is that I suppose I believe that, you know, the issue is you're going to economics, like you're talking macro scale really to address this. And the big issue is inequity. I do believe poverty causes homelessness and addiction. And I think economics causes poverty and also contributes. And we all think this over the last 10, 12 years, where it wasn't just, when the crash came, I remember predicting there'd be an increase in homelessness. But the reason I predicted it was I thought families are going to become more stressed. Kids are going to end up being more traumatized, end up using more drugs and crash out. And that did happen. And I thought you're not going to see it for 2 or 3 years, which was the case. What I didn't predict was then with the huge rise in rents, the difficulty obtaining rental accommodation, which contributed to that massively. So I suppose I'll go back. I don't think market economics, a fully uncontrolled market, I think that will work against equity and will work towards promoting homelessness. And I think it's interesting that we have seen since the market collapsed because of COVID, that suddenly all this accommodation has become free, and we're able to get accommodation much cheaper, and suddenly we're housing homeless people that we couldn't house before. So I think it's a real example of how when the market went, like the market didn't provide the solution, getting rid of the market provided the solution. So I think it's literally, the simple answer is higher taxes, more social interventions. And I'm not saying that it has to be, I think there's obviously private enterprise and there's private public things that do work, but I think much more leaning towards social intervention and tax economy. Yeah.
Okay. Just looking here. This is from Sarah Sheridan, who is from IREC, and Sarah says, thanks, Austin, for a really interesting presentation. Was wondering whether you had given thought to using these findings to inform training materials for medical students or a toolkit for GPs in addressing misconceptions of homelessness and tackling the pitfalls in communication breakdowns.
Well, thanks. Actually, what I did do is, one of the things I did find was what's called the North Dublin City GP Training Scheme in 2009. And it's actually the first GP training scheme internationally to try and seek to train GPs to work in areas of deprivation and with marginalisation. And that means we teach them about health inequities from first year. We place them in practice in areas of deprivation. In their fourth year, they've spent 3 months working a day a week in drug services, 3 months working a day a week in prisons in the morning and migrant services in the afternoon. Sorry, 4 months for both those, and 4 months a day a week working in homeless services. And the main focus of them working in these services, interestingly, is called Allport's contact hypothesis. Allport maintains the only way to break down stigma is through meaningful contact. So by us having them work with the clients, they're breaking down, they're working with them. So they're on a day, it's about that work and working with doctors who are very good. We only let them work with doctors who have good attitudes to working with homeless people. And by modeling themselves in those doctors and recognizing when you're working with homeless people, they're the same as anyone else, that's what breaks down the barriers. So having contact, for example, in a class where you bring a homeless person in and they sit in front of the whole class, that's not genuine contact, that's actually the medical gaze, where you sit and you gaze down as dispassionate medics, objective scientists. So so in this GP training scheme, we have found 97% of our graduates are working in areas of deprivation or with marginalisation. 55% are actually working in marginalised groups, that's either homeless, travellers, migrants, or prisoners, or drug users, and 11% are working full-time in those areas. So, and in fact, as a result of this, there has been 3 schemes started in the UK, one in Glasgow, one in Leeds, and one in Manchester. So that model is developing, and in fact, if anyone's interested, I'd love to start using that model as well for other specialties. I do think the idea, when I first started the scheme, everyone said you shouldn't. By putting this as a scheme for GP training in areas of deprivation and marginalisation, you're marginalising this issue. I think you need to actually highlight the issue to create a force of change within the system. Interestingly, by us being there, suddenly all the other schemes started talking about social medicine, and now we have a national social medicine curriculum that all schemes sign up to, that we developed in our scheme. So I do think by highlighting this, another interesting thing is everyone said no one will apply because no one will want to work in areas of deprivation. And ever since we started, we have the highest rate of applications in the country per head of per place we have. And this to me shows that actually young people do want to make a difference. That's why they enter medicine. So in fact, we just need to show them the path of how to make a difference.
That's very heartening. So Rehad has another question there, Austin, and he asks, how do you manage multi-morbidity in the homeless population?
Multi-morbidity, first of all, multi-morbidity is a big issue for deprivation. We know people in areas of deprivation live 5 to 10 years less, and of that less years they spend twice as long with multi-morbidity, around 10 years with multi-morbidity versus 5 years in the wealthy populations. Most people, this just becomes our story called the cliff face. You're going down the slope of poverty with health industries, and then you reach the cliff and it just plummets over the cliff. So, in terms of managing multi-morbidity, it's literally about treating each of the conditions and also often trying to reduce the causes of it. So obviously smoking is a big cause for COPD, which is very common in the population. And there is a danger of giving up because 95% of homeless people smoke. So there's a danger you think, well, why bother trying to stop smoking? The other way of looking at that is if 95% smoke, even if you've only a 1% success rate, that's still, one person. If a 5%, it's 5 people. So it actually is well worth trying to address these preventative issues. So I think it's about doing the best you can. I do think, though, The real answer is get that person into accommodation. And as I said, going back to what's happening at the moment, interestingly, since we got people into accommodation, we find it easier to try and get them to comply with their medication. And also in the local casualties, they're saying they're seeing a huge drop in the amount of homeless people attending for general conditions, not just COVID conditions, but general conditions. So obviously housing is a big part of the equation to addressing morbidity.
Okay. So that's it. I think people are a bit. Yeah.
Obviously, your drug addiction, you can't manage your multiple morbidities. You have to address the drug addiction. Similar to housing, you have to address that.
Okay. That's the last question I got in, Austin. I think people might be a bit shy with the technology. But we'll wrap it up there because I know that you've got another engagement directly after this. So I want to thank you very, very much, Austin. I appreciate your time you gave us to this talk. It was really, really fascinating. And I would implore people to source the paper. It's a really, really interesting read. So I hope everybody enjoyed the presentation. There's a survey. So when you log out, there's a quick survey. If you could engage with that survey, it's very, very valuable. We just want to improve this this series as it progresses. And we'll leave it there, Austin. Thank you very much.
Thank you very much, Daniel. I really appreciate it.
Bye bye.